which seems like it's a franchise process.
Mm-hmm.
A doctor in California that was a chiro and orthopedic, and he just sounds kind of sketchy to me. And then Emory, and I'm going, well, Emory, I know Emory, and I'm flying in and out of Atlanta anyway, so it was, and then reading your credentials, it was pretty good. So
yeah, we like to think that, yeah, we do a good job. We think that this is something that is in a new treatment space, and we're trying to be on the cutting edge of it, trying to offer a good treatment and novel treatments for our patients. We pass the curve in there. But yeah, I always say that each year that we do this, I truthfully tell more people no than I tell them yes.
and why is that?
Because it's
joints too far gone?
Yeah, either the joint's too far gone or they haven't done the things that they should do before doing stem cell. You know, because like when we talked, I said, well, what have you done for your knee before? What have you done for your hip before? As opposed to, yeah, you're here.
Not going to give me any romancing.
Oh, I was talking. All that talking was foreplay right there. All right, pinch.
Oh.
Okay. Right.
So what kind of devices do you prefer, Stryker or Biomed?
That is 100% surgeon determined, or should be surgeon determined. It is going to be what they are comfortable with. A surgeon who is more comfortable with Stryker should not use Biomed, pinch again, and or vice versa. There are different reasons why different surgeons do what they do. Alright, there we go. You're going to feel this probably going down your leg a bit.
Ooh.
See, that's it. That white going underneath, that's it going underneath the joint capsule.
Ooh. So there was no numbing on that one, huh?
That's what I said, no romancing at all. Have me exposed in the...
The knee actually gets a little bit more romance than the hip does.
Well, thanks.
It's all about the romance.
It's all about the
Yeah,
romance.
exactly.
Want me to hold your hand? Or you're good?
No. Oh, you want me to straighten this one?
Alright. That line is where we want to get for your fluid. It does have some fluid in there. Can you look in there, in that top drawer, see if there is a syringe in there?
Is that black part the fluid?
Mm-hmm. So I'm going to just take the needle off of the top of that and put it on there.
You're going to drain me first.
Yeah, I'm going to take off some. There's not a lot of fluid, but since I can see it, since I can get to it, take it out so it doesn't dilute what we're putting in.
Okay.
I'm probably only going to get maybe 5 or 10 cc's out of there, which is not that much, but still should drain that if I see it. Cold spray.
Yeah, that's cold. Well, it's because Barb took me to a couple of concerts the last few days, and
Ah, there you go. Stick.
so first one was the band Perry,
Ah, really?
country, and then got invited to go see Eric Church the next day. I'm standing room.
Oh, man, that isn't.
Prolonged standing is just not fun.
How many people got? Let's see. There's some more. No. There's less fluid in there than I thought. Oh, we got some out.
Well, thanks for keeping the needle in there, Doc.
You're welcome. So you don't have to get stuck twice. Can you ask Christine for another 18? See, you had to say that, didn't you?
I'm sorry.
Because now there's a little, every so often we'll get a little bit of the fat stuck in the needle, and yours got stuck. So I just have to get another needle and go again. It'll be okay. That's not a problem. It's not something that went wrong, but every so often it does happen. And it's usually when I don't say, you know what, sometimes it gets stuck. It does. And most of the time, if I take off fluid, it doesn't end up sticking, but this time it did. Can I get that ethichloride again, please?
So we were asking the question about massages. I
Mm-hmm.
generally get massaged periodically. Is any restriction, any concerns about?
No. You may not want to do that today, tomorrow, just because it's a little sore. But
Yeah.
if you find that the massage helps, stick again.
More concerned about where you took the marrow out.
Oh no, that should be fine.
Oh, cool.
Done.
Yes, sir.
So, you got all this goo injected into me.
Mm-hmm.
I think you call this the seeds,
Mm-hmm.
and then we're going to do the platelet-rich plasma after this
Mm-hmm.
in 6 weeks or so, 5 weeks, whatever.
Yeah.
Which is like fertilizer, you kind of explained.
Yeah. What this is, this go round, we're putting in the stem cells. The stem cells will go in, find where the damage is, and do their work. The thing is that no matter how much you put in, whatever amount you put in, there's a certain percentage that will actually join in and start getting activated and do their work, and a certain amount that won't see good action.
Okay.
When we come back with the platelets, what the platelets do is, if there are any cells that weren't activated, or not if there are, the cells that did not get activated that first round when we put them in initially, will now be turned on and do their thing. So it's basically not so much a fertilizer as it is a second go at activation, because there's some cells that went in there and just said, I'm not doing anything. Everybody, there's too much space in there, not enough space for me to do my thing. They shut down.
Okay.
The platelets come back in and turn on any of the cells that weren't turned on the initial. So you get a higher yield of activation and in turn productivity of, or not productivity, but a higher yield of the repair, the potential repair process.
Okay. So, will this help glue down tears of cartilage, rebuild cartilage,
it
and
is-
do any of that?
It's very,
So-
it's a nuance. I am being very careful about what I say because the research in the lab and what we're seeing in the anecdotally are slightly different. In the lab, you put not slightly different, but we can't translate that directly. You put a stem cell beside a cartilage cell, the stem cell turns into a cartilage cell. But that one stem cell doesn't turn into a million cartilage cells. So when we put 100,000 stem cells into your knee, and they sit there, they're only going to form 100,000 cartilage cells. So it's going to lay down potentially a thin layer of cartilage there. It's not going to then repair and then regrow back to rebuild back. So it's more repairing rather than, in the true sense, rebuilding or regenerating cartilage.
Okay. So, bottom line, I should feel some relief.
Yes,
The
should.
swelling should hopefully start ceasing in the knee.
Mm-hmm.
The pain hopefully will start going away in the hip, and
Yep.
hopefully I can get back to more full mobility on it.
Yeah,
And-
especially if the mobility decrease is being caused by pain. If pain is kind of the driver that's not allowing you to get there, you will increase. But some of that decrease in mobility around your hip is mechanical. That head just doesn't turn as well because there's an osteophyte there. That is not going to necessarily improve. It will get you where the motion that you have should be more pain-free,
Okay.
but may not get you a totally wider range of motion because some of that is mechanical because you have a bone spur there.
Okay.
Okay.
So, okay, maybe you're answering my question already in that fact that, like, this knee, I can lay down this leg. I can go flat. This leg, I can't do that. And some of that, I think, is
Tightness.
tightness in the
Yeah.
joint or in the muscular.
For as much of that is due to tightness, and that tightness is likely due to the fact that you have chronic pain there. That will improve. But there's going to be, bend your knee, there's going to be a point where, like from here to here, you stop there. From here to there may be because of muscle tightness due to pain. But there's also going to be a hard stop where, because you have arthritis, you're not going to be able to get it all the way out
Okay.
like that.
So it's still reasonable then to continue to try to stretch that.
Oh yeah, yes, absolutely.
And not limit that motion
No.
because